Okay, so let's talk about hypertensive disorders of pregnancy. If you have already done the PowerPoint that talks about magnesium sulfate for neuroprotection, I talk a little bit in there about checking reflexes. That will be covered more in depth in this presentation. So if you're worried about checking reflexes on somebody who has magnesium sulfate running, we're going to talk about it in this presentation. Okay, so what are hypertensive disorders of pregnancy? So it kind of starts as just hypertension by itself. 26% of this will be chronic hypertension, as in they had it before they were pregnant. This doesn't have to do with pregnancy. And then there will be a number of the population who will get gestational hypertension. It is caused by the pregnancy. It's about 25%, and then under 35 weeks, it says 35% there. So then that's where it starts. Hypertension, which is either chronic or gestational. Then preeclampsia, which is defined as hypertension plus proteinuria and or end organ dysfunction. That can lead to HELP syndrome and then to PRESS. And when we get to each of those syndromes, we will talk more in depth about what that means. So just gonna make myself a little bit smaller so we can see this. So hypertensive disorders of pregnancy are responsible for about 22% of all maternal deaths. Like, these things happen. We are very fortunate that we live in a country where we can treat it. We always feel very badly when this happens with our patients, and if there's a bad outcome or if it's gotten to the point of HELP syndrome or PRESS. However, keep in mind that in other countries, they don't have the management resources that we have. They wouldn't have their patients on antihypertensives. They maybe wouldn't be able to access early delivery the way that we can. And so the rate of death is actually quite a bit higher than it is here for hypertension. Women with severe preeclampsia have poorer health-related quality of life, often related to perinatal death or the admission of their infant into NICU. Preeclampsia is likely not a single condition, but rather a condition with several subtypes, but we don't know enough yet. This would account for the varying clinical presentation and lack of highly useful predictive tests or preventative interventions. So a few definitions. Hypertension is defined as a systolic blood pressure above 140 or a diastolic blood pressure above 90. So if you've come to us from Med-Surg, you might not worry too much about a diastolic blood pressure of 90, but we do. Severe hypertension would be a systolic above 160 or diastolic above 110. So your classifications, I alluded to this on the earlier slide, but let's get into it more. Chronic hypertension pre-pregnancy or before 20 weeks. So if you're diagnosed with hypertension before 20 weeks, there's a 21% chance of developing superimposed preeclampsia. Those who do not develop preeclampsia are still at an increased risk of cesarean section, perinatal mortality, and a small for gestational age baby. Gestational hypertension, the onset of the hypertension is after 20 weeks of pregnancy. No other maternal organ dysfunction, 25% chance of progressing to preeclampsia, 35% gestational hypertension before 34 weeks gestation. Preeclampsia is chronic or gestational hypertension plus one or more new onset conditions: proteinuria, maternal organ dysfunction, and uteroplacental dysfunction, which would cause fetal growth restriction. So maternal complications of preeclampsia include stroke, pulmonary edema, hepatic failure, seizures, placental abruption, acute renal failure, and death. Fetal complications. NICU admissions are at about 20%. Fetal growth restriction, 30%. Oligo, metabolic acidosis, so a 5-minute Apgar under 3, or umbilical artery pH of less than 7. Preterm birth, death. Chronic hypertension is associated with increased risk of congenital malformations in the newborn, particularly cardiac, independent of antihypertensive use. And then the risk to the offspring. So the risk of depressive symptoms in adulthood is increased in offspring of women who developed preeclampsia. These offspring may also have increased risk for impaired cognitive functions in childhood and adulthood, and they are more likely to be hypertensive by age 21. They can demonstrate an abnormal lipid profile in early adulthood. And then future maternal risk. Cardiovascular disease, diabetes mellitus, and metabolic syndrome increase the risk of chronic kidney disease. Women who develop preeclampsia before 37 weeks gestation are at significant risk in subsequent pregnancies of stillbirth, placental abruption, spontaneous preterm retro-membranes, small first gestational age babies, even in the absence of preeclampsia in the subsequent pregnancy. So what that means is if in your first pregnancy you had preeclampsia, and in your second pregnancy you did not, you still have the risk for these things. So what's the pathophysiology behind this? The latest theory is that it's failure of the maternal cardiovascular system to adapt to pregnancy. It's a theory. With required remodeling of arteries, reduction in arterial stiffness, and enhanced endothelial function. It's a two-stage process, we believe. In stage 1, there's inadequate placental perfusion. So then in stage 2, there's maternal syndrome resulted from the materials generated by this insult. So despite decades of research, the cause remains unknown. We're not sure. Is it abnormal placentation or excessive fetal demands? That can lead to a mismatch between uteroplacental supply and fetal demands, which then leads to maternal endothelial cell dysfunction, which then leads to manifestations of preeclampsia. So this is endothelial cells, and it just kind of shows the dysfunction that may be there with vasospasm and
all clear.
Sorry. These are endothelial cells. So it shows in this picture fibrin deposition, vasospasm, it activates platelet aggregation, tissue ischemia from impaired blood flow, decreased vascular volume. All of these things are connected. I like this slide a lot. I'm just going to move my face down because this kind of shows you the symptoms that we often ask about. So if we have arteriolar vasoconstriction and systemic vasospasm and vascular damage, that then leads to a lot of different things. So starting at the top, altered organ perfusion, which up here, underneath all of this stuff, talks about kidneys, and that it reduces your blood flow and GFR, which leads to proteinuria, glomerular endotheliosis, increased plasma in the urine, uric acid and urea, and causes oliguria. Decreased hepatic blood flow then leads to your liver tenderness and enlargement, epigastric pain, elevated liver enzymes, and hemorrhagic necrosis. retinal arterial spasm leads to blurring and scotoma, so the floaters in your vision. Decreased placental blood flow leads to increased intrauterine activity, intrauterine growth restriction, and infarctions and abruptions to the placenta. So then if we look down here, we have fluid shifts from intravascular to the extracellular space, which can lead to cerebral edema and CNS irritability. That's our headaches, hyperreflexia and acrophonus, nausea and vomiting, and eventually convulsions. Decreased intravascular volume leads to an increased hematocrit. Increased interstitial fluid in the lungs leads to dyspnea and pulmonary edema. And then down here, intravascular fibrin and platelet deposition leads to DIC. Decrease in the platelet count and increased clotting time. So when we are evaluating somebody for hypertension, we ask our patients, are you having a headache? Any blurred vision or floaters in your vision? Any epigastric pain? Nausea, vomiting? Like, these are the normal questions we ask if somebody presents with a headache, because we are looking for these symptoms. And if these symptoms are present, that means the disease process may have gotten far enough along. So how do we properly assess a BP? This is kind of important because, especially with our postpartum hypertension scoring tool, you just kind of look and you see if they've had a high BP documented somewhere. It doesn't specify this high blood pressure was immediately upon arrival and they had just run up the stairs. And it doesn't specify like they were in the middle of a contraction when the blood pressure cuff went off. Like, it doesn't show you those things. So it is important that we get an accurate blood pressure reading. So we want a minimum rest period of 10 minutes after arrival, and in a sitting position with upper arm at heart level. An appropriate size cuff. So if it's too small of a cuff, it will overestimate blood pressure. If it's too large of a cuff, it underestimates blood pressure. Never place over clothing, even if it's a thin shirt, you shouldn't place it over top. The length of the cuff should be appropriate. So just look at your cuff. They have lines on them for how long they should be for somebody's arm. A manual is the best. Automatic machine can underestimate by 10 to 15 millimeters of mercury. If it's consistently higher in one arm, that arm should be used for all measurements. So when I have somebody come in, I let them go to the bathroom, have them come and sit down on the bed. I have them in high Fowlers, talk to them a little bit. I put the blood pressure cuff on, and then sometimes I'm sneaky about it. I'll set a little timer on it so they don't know when it's going to go. And in the meantime, I'm assessing their baby and asking them all the other questions. And then I let the blood pressure cuff go on its own so that they're more relaxed. Because sometimes we'll have people come in and they have white coat syndrome and they just are elevated anyways. So if you know somebody has a history of hypertension, however, you should be doing a manual BP for sure. Okay, so how do we diagnose this? So if it's above 140 systolic or 90 diastolic and on at least 2 measurements taken in the same arm more than 15 minutes apart. So if your first reading is high, stop and just have her sit, have her rest, and then do it again in 15 minutes to see if it is still high. If it is severe, above 160 on 110, we just need to act faster. Important to note that women with a high BMI have blood pressure readings that are 4 millimeters per mercury higher than women with a normal BMI. So following confirmation of hypertension, assess for maternal organ involvement. So say you got that first reading that's a bit high, well, leave the cuff on, set it to go in 15 minutes, and then start asking her some questions. Do you have a headache? Any visual disturbances, blurred vision, especially floaters in your vision? Any irritability, any tremors? Does she have hyperreflexia? Any chest pain, dyspnea, distended neck veins? Any vomiting, nausea, vomiting, bleeding, any petechiae on her body? Does she have right upper quadrant epigastric pain? And that's due to spasm of blood vessels in the liver capsule. Severe nausea and vomiting would be due to liver distension, and renal would be proteinuria. So that's why, like, when people come in complaining of some of these things, you get a urine sample right away, and you can dip that for protein and also send it to the lab. UA will show you how much protein there is. So on all of these patients, we always used to do a 24-hour urine, and it's quite cumbersome to do. So urine protein of more than 300 milligrams a day on a 24-hour urine collection is the gold standard for diagnosis of proteinuria. If it's 2+, more than 2+ on a dipstick, it's highly suggestive of proteinuria. Proteinuria of 1+ should be confirmed by a 24-hour urine collection because there's a significant false positive and false negative result. But a urine PCR of 30 milligrams per millimole is suggestive of proteinuria. So that's what we normally send. We'll send a UA with a urine PCR attached to it. And if it's above 30, she has protein in her urine. If it's below 30, that usually rules it out. It's less cumbersome than a 24-hour urine. Could we still do a 24-hour urine? Yes, we can, but they tend to not order it as much. Protein in the urine is protein in the urine. So samples that are not the first void were found to have a sensitivity of 90%. The degree of proteinuria, high versus low, has no impact on worsening maternal nor perinatal outcomes. So that's why we say if we send a urine PCR and there's proteinuria, we don't need to know exactly what it is in a 24-hour period. It is there. And so what that number is isn't going to tell us a lot more. We need to do more assessment of other things to know. So in our hospital, we do a urine PCR instead of a 24-hour. So things that are suggestive of preeclampsia, but not diagnostic. If the mother has oliguria of 15 mils an hour, edema, weight gain, and reflexes. So many pregnant women will have edema in their pregnancy, and especially towards the end of pregnancy. And that can be normal. It can also tell us that she might be struggling with her blood pressure. Many pregnant women, as the baby moves down in the pelvis, it makes it harder to pee. And so they might go to the bathroom and have low urinary output, but they're going to the bathroom many, many times. It's suggestive, but not diagnostic. Many pregnant women put on a lot of weight during pregnancy. That's suggestive, but not diagnostic. So what's some other maternal testing that we can do? Checking SATs. If it's below 97%, well, there's something going on with her lungs, perhaps, or she's a smoker. Hemoglobin. So it can be increased due to vascular space depletion, or it can be decreased if she's going into HELP. Creatinine and uric acid are increased, and hemo concentration and renal failure. Uteroplacental testing. There can be decreased uteroplacental perfusion due to decreased systemic blood flow and vasospasm. This can also initiate labor. We could have a placental abruption, fetal growth restriction, oligohydramnios, because as that baby's getting less perfusion, the baby's kidneys are affected, and so it produces less urine, which is less amniotic fluid. Atypical or abnormal fetal heart health surveillance. We can do biophysical profile and umbilical Dopplers to look at what the blood flow is like in the placenta. And then this can lead to hypoxia and fetal death. So early onset of hypertension, less than 34 weeks. Early onset of preeclampsia or severe hypertension warrants considerations of further investigations, looking for underlying conditions or alternate diagnosis. Okay, so how would we manage hypertension? So there are preventative things that we can do. One is low dose aspirin. It lowers the risk of preeclampsia in higher risk populations, that people, such as people who have chronic hypertension, diabetes, or previous preterm preeclampsia. And it's just 81 milligrams to 162 milligrams, so 1 to 2 pills, results in a 10 to 17% decrease in preeclampsia. It needs to be initiated before 16 weeks. No evidence for low risk populations, so we don't do it with everybody. Taken once daily at bedtime, started pre-pregnancy or as early in pregnancy as possible, and continued until the end.
Stroke alert, emergency. Stroke alert, emergency. Stroke alert, emergency.
The benefits were not observed when aspirin was initiated after 16 weeks. Prevention. You can do calcium supplementation, a gram a day or more, or an increase in dietary calcium intake, so 3 to 4 dairy servings per day. It decreases the rate of preeclampsia in low and middle income countries populations with a low dietary intake of calcium. In general, management includes evaluation of the mother and the fetus, prevention of severe maternal complications, prevention of severe fetal complications, symptomatic support, delivery. It's important to note that deterioration can occur very quickly. So, antihypertensives. We do this to reduce the risk of stroke in the mother. It does not reduce the risk of seizures, which would be eclampsia, or prevent adverse fetal outcomes such as IUGR. It's to reduce the risk of stroke. Too rapid a drop in maternal blood pressure may cause a reduction in uteroplacental perfusion, resulting in fetal compromise. So we don't want to drop her blood pressure so quickly that the placenta detaches, is what that means. So we do have to be cautious about dropping her blood pressure. Therapy should aim to reduce the systolic blood pressure to less than 160 and the diastolic to less than 110 over a few hours. The ideal blood pressure associated with the optimal maternal and perinatal outcomes is unknown, but a reasonable goal is 130 to 155 and 80 to 105 for your diastolic. Labetalol. So this is what our patients are often put on first, and they're often put on oral first simply because they have a mouth and not an IV when they show up. So this is a beta blocker. It does have a rapid onset of action with both PO and IV dosage. Your dosage range can be between 100 up to 600 milligrams once a day up to 4 times a day. The maximum would be 1,200 milligrams in a day. You always want to take a blood pressure before you give it. Even if it's a scheduled med, take a blood pressure before, because there might be hold parameters. It might say if her blood pressure is below 90, not to give it, and that is because we don't want to drop it too low. And then take another blood pressure 30 to 45 minutes post the oral dose, see what her blood pressure came down to. and use with caution in patients who have asthma. Nifedipine is a calcium channel blocker. This is a slow release drug. And so normally we would give 30 milligrams twice a day, up to 60 milligrams twice a day. It's not for acute. So we start with the labetalol and then we go to nifedipine. The onset is 30 to 60 minutes, duration 2 to 3 hours, up to 6 hours. It's eliminated in the liver. So sometimes we'll use it. We could use 10 milligrams immediate release for hypertension, but we need to use that very cautiously, especially with IUGR babies. The side effects of nifedipine are nausea, flushing, palpitations, headaches, dizziness, heartburn, peripheral edema, neuromuscular weakness, hypotension, reflex tachycardia, pulmonary edema, and atrial fib, or an MI. Very rare, but can happen. Methyl dopa, I haven't seen this given here for hypertension, but it is something that you could come across at some point. The initial dose is 250, maximum is 500 milligrams QID, but it can cause depression. So other medications that patients may be on. ACE inhibitors such as ramipril or captopril and angiotensin receptor blockers such as losartan and valsartan are contraindicated because of intrauterine growth restriction, prematurity, and oligo. So they're not teratogens, but they do disturb the fetal and neonatal renal function. So women who conceive on them should be switched to alternate antihypertensives as soon in pregnancy as possible. So you shouldn't see your patients come in on these, and if you do, that medication needs to be changed. So symptomatic support that we can do, antiemetics, a quiet environment, supportive family and professionals, clear explanations of a plan, minimize negative stimuli. We don't do strict bed rest. That can be harmful. It can cause blood clots. So taking it easy, yes. Resting, yes. But strict bed rest to the point that you're not even getting up to the bathroom, no. You can walk around. You can be kind of active in your room. But I mean, maybe now is not the time to go for a run. A component of maternal hypertension is adrenergic and may be modified by stress reduction. So, you know, this is her first baby and her mother-in-law is driving her crazy with all of her expectations. You got to decrease that negative stimuli for her so that she can relax. Fluid management. So hypertensive women may not tolerate large fluid volume shifts. And pulmonary edema is definitely a concern with these women. So intravenous and oral fluid intake should be limited. The type of fluid is not as critical as the volume of fluid. It's not unusual for there to be a decreased urine output. In the absence of pre-existing renal disease or a rising creatinine level, oliguria should be tolerated for at least a few hours. So we don't want to bolus her just so that she pees, is what that means. Do not administer dopamine or furosemide in the presence of persistent oliguria occurring prior to delivery. So we have to be careful how much fluid we give these women. Don't just go in the room and like, oh, I think the fetal heart rate looks a little funny and open the fluids. That's why we don't do that anymore. We want to minimize the amount of IV fluids she's getting. So risk factors for predicting maternal and perinatal morbidity and mortality in patients with established gestational hypertension and preeclampsia. So the earlier in gestational age that the preeclampsia happens, the worse the outcome. normally is. If she has chest pain or dyspnea, not great. Low oxygen saturations, not great. Low platelets. As her platelets start to drop, that's a reason for delivery. Elevated creatinine, elevated AST. These are excellent predictive values of adverse maternal outcomes occurring within 48 hours and up to 7 days. An oxygen saturation of less than 93% was very predictive of poor maternal and neonatal outcomes within 48 hours. So when you are assessing people on assessment, or if they came as a direct admit to high risk to team 3, you should do an oxygen sat on them. We should be doing that on all of our patients on admission. Be doing at least one oxygen sat when they're admitted, and then anytime we are concerned, we should do it. So we've talked about all of these treatment things that we can do for preeclampsia, but what is the cure? The cure is delivery of the placenta, not the baby, but the placenta, and we can't deliver the placenta unless we deliver the baby. Any of the hypertensive disorders of pregnancy can progress quickly to endanger mom or baby. Timely delivery minimizes maternal and neonatal morbidity and mortality. Maternal status must be optimized before intervening with the delivery process. Delay of delivery to allow transfer should occur only when maternal and fetal conditions permit. Corticosteroid therapy to enhance fetal pulmonary maturity should be considered for all women with preeclampsia before 34 weeks gestation. Expectant management is potentially harmful. Maternal status can worsen and eclampsia can still occur after delivery. So our treatment of delivery, the suggested time of delivery, it's a very broad generalization. If she has chronic hypertension at or above 38 weeks, gestational hypertension at or above 37 weeks, preeclampsia without severe features about 37 weeks, preeclampsia with severe features such as inability to control maternal blood pressure, increasing maternal organ dysfunction, neurologic symptoms and health, fetal indication for delivery, and then we're going to deliver regardless of gestational age. Eclampsia. So eclampsia is a seizure. The following symptoms can predict eclampsia for us. Right upper quadrant pain. So that shows us that her liver is involved, right? And it's leading to more and more severe symptoms. A headache, visual disturbances, especially floaters in the vision, and vomiting. So warning signs: severe persistent headache, epigastric pain, hyperreflexia with clonus, restlessness, facial twitching followed by generalized muscle rigidity. So to describe an eclamptic seizure, generally will last about 60 to 75 seconds. Patient may foam at the mouth, respirations may cease. Usually happens in 2 phases. So in phase 1, it lasts about 15 to 20 seconds, and this just starts with facial twitching. Then the body becomes rigid, leading to like generalized muscular contraction. That's your tonic-clonic part. So phase 2 lasts approximately 60 seconds, and this is your tonic-clonic seizure. Muscles will begin alternating between contracting and relaxing in rapid sequence. Post-seizure, there's normally a coma or unconsciousness following phase 2. Sometimes when people faint, they have a vasovagal response, you'll sometimes see their arms come up and they do this. And that is part of their blood pressure dropping quickly. And that's their body's reaction is to do this. And then when you wake them up, they look around for a second and then they're oriented. You can ask them where they are. They remember where they are. They don't know what just happened. They fainted. They don't know that they fainted, but they're easily orientated. If they have had a seizure, normally will last longer. So these seizures are, like we said, about a minute, 15 seconds. And when they wake up, they are not orientated. There's a post-ictal phase where they are often confused. So unconsciousness can last for a variable period. Patients may become combative and agitated when they wake up. They have no recollection of the seizure. There's usually a period of hyperventilation right after the seizure because they stopped breathing during it. And so they're reoxygenating their body. So this compensates for respiratory and lactic acidosis. Seizure-induced complications may include tongue biting, broken bones, or aspiration. So what immediate actions do we need to take during the seizure? Always helps if we don't panic. Protect her from harm. So that means bed rails up so she doesn't fall off the bed. You can pad the bed rails if you can get pillows in there so she's not hitting them so much. Glasses off, sharp objects removed. The current practice is not to introduce an airway to facilitate tongue depression or inserting anything into the mouth. That used to be taught to do that, and it hasn't been taught for many, many years. And the reason why it hasn't is they used to say, put something in their mouth so they don't bite their tongue, but they would end up biting that thing and then choking on whatever it was. So what's our incidence of eclampsia? It happens in 1 to every 2 to 3,000 deliveries. So if you think about us here in Saskatoon, we do 5,000 to 6,000 deliveries a year. We should see this. When are they most likely to occur? 50% happen before labor, 25% during, and 25% early postpartum. So some of the eclamptic seizures that happen outside of the hospital. They've already gone home because we send our patients home usually 24 hours later. So this is why it's so important to flag people who are at risk and to be doing frequent blood pressure monitoring on them. So I feel like I don't know that we see 2 to 3 seizures a year in the hospital always, but keep in mind that it might have happened in the community. So what's our treatment if somebody has an eclamptic seizure? We want to give a magnesium sulfate bolus of 4 grams over 20 minutes, and then a maintenance dose of 1 gram an hour. This decreases CNS irritability and therefore decreases the chance of subsequent seizures. If she's already on magnesium sulfate and she has another seizure, then we would rebolus with 2 grams over 20 to 30 minutes. 2 grams of magnesium. And then you want to assess for evidence of a placental abruption. Watch the patient for development of a DVT, CVA, or cardiomyopathy. So deep vein thrombosis, a stroke, cerebral vascular accident, or cardiomyopathy. So why do we use magnesium sulfate? That's a good question. It's used to prevent seizures. It can decrease your seizure risk by 50%. What's the mode of action? It's a neuromuscular blockade. And the recommended dose is 4 grams IV over 20 to 30 minutes, followed by a maintenance dose of 1 gram per hour. Selective use of seizure prophylaxis is generally recommended for women with severe hypertension, blood pressures below the severe range, but with associated significant headache or clonus, visual disturbance, right upper quadrant or epigastric pain that is severe and persistent, and or elevated liver enzymes, thrombocytopenia, and progressive renal insufficiency. So this is showing us that we are progressing in this disease process, and every step you go down to progress there, you're at a higher risk of a seizure. What do we do if a second seizure occurs? Repeat your make self bolus, but this time it's 2 grams. And then we would consider benzodiazepine. So diazepam, 10 milligrams IV, but you need to watch for apnea and maintain oxygenation and the need for anesthesiology assistance. So if you're giving that much diazepam, you would like anesthesia to come. Ativan, 2 to 5 milligrams IV. Again, be careful how much you give her so that she doesn't stop breathing. Midazolam, 2 to 4 milligrams IV. And again, you're always being cautious here. We are lucky here in Saskatoon because we have the benefit of having anesthesia on our floor. They could be busy in the OR, but they can always call for help. And normally we have 2 anesthesia here during the day shift. So what's nice is if we have a patient that had an eclamptic seizure, we're going to start the mag self bolus, but anesthesia is also going to come, and they will help us with the benzodiazepines. Anti-epileptic medication is sometimes used as well. Dilantin is the drug of choice per SOGC guidelines. We do keep, when you give Dilantin, you have to give it through a filter. So the Dilantin filters are in our OR core. There's a box of them there. All of our seizure kits have a note in them that says where to get Dilantin and where to get the Dilantin filter. They expire, and so that's why they're kept together in a box. The Dilantin is in the Pyxis in recovery room and the maternal ORs. You might need to get like 3 from one Pyxis and 3 from another Pyxis to get however many vials that you need. But we do have it here. We've only had to give it, like there's only one time in recent memory that we've used it, but we certainly have it here so that if we ever needed it again, we have it. Okay, so assessing reflexes. This is something to practice. I alluded to this in the presentation on preterm labor when I talked about giving magnesium sulfate for neuroprotection. And this is where we're going to talk about it more in depth. So if we have absent deep tendon reflexes, that is indicative of magnesium toxicity. If we have brisk, clonus, or worsening deep tendon reflexes, that's not predictive of seizures, but it indicates a disease state of the central nervous system. So hyperreflexia, that's brisk reflexes, are the result of an irritated cerebral cortex and indicate CNS involvement. If there's CNS involvement, the potential for seizures exists and magnesium therapy should be considered. Okay, so there is an attached video that came in the e-learning module, and so I want you to watch that to see how to check for reflexes and what clonus would look like. The clonus is a strong, deep tendon reflex that occurs when CNS, the central nervous system, fails to inhibit it. It's a sign of neuromuscular irritability, and we would count the number of oscillations that there is. Okay, let's talk about HELP. HELP is an additional complication of severe gestational hypertension. The management of HELP syndrome consists of all therapeutic steps for hypertension described above, but also the thrombocytopenia may require specific intervention based on severity. So what does HELP stand for? The H in HELP is hemolysis. This is the destruction or shredding of red blood cells. Occurs when severe vasospasm reduces the lumen of the arterial vessels and the velocity of the blood flow propels red blood cells through the resistant small lumens. So we damage the cells. We look for the following things: falling hemoglobin and hematocrit, abnormal red blood cells on a peripheral smear, hyperbilirubinemia, and jaundice sclera. The EL in HELP stands for elevated liver enzymes. So the maternal liver failure results from microemboli in the hepatic vasculature, which causes ischemia and tissue damage within the liver. So look for the following things. There will be increased AST and ALT, feeling of malaise, viral-like syndrome, and it can cause epigastric right upper quadrant or shoulder pain. LP stands for low platelets. So there will be a decreasing platelet count. Mild, your platelets would be between 100 and 150. Moderate, 50 to 100, and severe is less than 50. So you want to assess for clinical signs and symptoms of bleeding, such as petechiae, easy bruising, bloody noses, gingival bleeding, bleeding from the eyes, and oozing from the IV site. So if platelets reach a certain level, anesthesia won't want to do a epidural. And that the number that is the certain level differs for each anesthesia, but dropping platelets is an ominous sign. So it's something we need to always take note of. And if it's below 70, she may not be able to get an epidural. So that is what HELP syndrome is. Now, PRESS is posterior reversible encephalopathy syndrome. What is this? It's a clinical symptoms plus radiologic findings. So they'll do an MRI or CT scan and they will see a difference on that. Severe headaches, altered mental status, seizures, visual loss, white matter edema, predominantly affecting the occipital and parietal lobes of the brain. Persisting headache in women with severe preeclampsia provides an indication for performing an MRI scan to exclude the presence of CNS-related pathological conditions. The cause of PRESS is not yet understood, but possible etiologies is autoregulatory failure with resultant vasodilation, vasospasm with ischemic change. Several factors can trigger the syndrome, such as acute elevation of blood pressure, abnormal renal function, immunosuppressive therapy, preeclampsia and eclampsia, transplantation, neoplasia and chemotherapy treatment, systemic infections, and renal disease, acute or chronic. The treatment: lower blood pressure to prevent irreversible ischemic brain injury. So you can see as we move from gestational hypertension to preeclampsia to eclampsia and HELP and PRESS, you can see the progression of the disease process, and our goal is always to bring it back down. Okay, so postpartum management. Gestational hypertension and preeclampsia may present initially or worsen following delivery. So sometimes people don't have it in their pregnancy or during labor, and it first presents after. The peak time for the appearance of hypertension postpartum is on days 3 to 6, when the mobilization of the extracellular fluid accumulated during pregnancy occurs. So often they have peripheral edema after having a baby, some people do. And when that fluid shift happens, that's when we might notice a problem with blood pressure again. Women who have received magnesium sulfate for seizure prophylaxis during labor should have it continued for the first 24 hours postpartum. All women at risk for hypertensive disorders of pregnancy must be monitored carefully in the postpartum period with ongoing attention to blood pressure, renal function, seizure risk, and end organ dysfunction. Lab investigations should be directed towards the particular end organ that has been affected. For women who had severe hypertension in pregnancy, the addition of postpartum Lasix, furosemide, for example, 20 milligrams by mouth every 24 hours for 5 days, to the antihypertensive regime appears beneficial in lowering blood pressure and then in reducing the need for other antihypertensive medications postpartum. Postpartum thromboprophylaxis should be considered, particularly if there has been antenatal bed rest for more than 4 days, if the patient is obese, or if delivery has been by C-section. Severe postpartum hypertension should be treated with antihypertensive therapy to keep the systolic blood pressure below 160 and the diastolic below 110. Antihypertensive therapy should be considered to treat non-severe postpartum hypertension, particularly in women with comorbidities. Antihypertensive agents acceptable for use in breastfeeding include nifedipine, which is Adot, labetalol, methyldopa, captopril, and enalapril. Although rare, new onset preeclampsia has been documented up to 3 weeks after delivery in an otherwise normal pregnancy. Advanced maternal age, diabetes, obesity, and being of African or Latina heritage seems to be associated risk factors for these occurrences. So because of this is why we do the postpartum hypertension scoring. And then if we know somebody has risk factors, we send them home with high blood pressure in pregnancy and postpartum teaching. And we want them to monitor their blood pressure. We give them very clear parameters of when to present back to the hospital. And if they come back within the first 6 weeks, they need to come here to our maternal triage. We know what HELLP syndrome is. We know what gestational hypertension is, and we treat it quickly. In Emerge, it's just somebody coming in with a headache, and they might say, well, that blood pressure is not that bad. And they don't, maybe they don't have the same experience that we do to spot this and to quickly treat it. And it does need to be treated quickly so that she doesn't have a stroke. So this talks about their rest periods at home, what they can, they can do things. You can be up and about at home, but avoid heavy work and rest with your feet elevated. And that's just to help with fluid shift. The swelling that happens with pregnancy can be worse in the first few days after delivery. And that's very true. Some people, like for example, I was preeclamptic and I was given too much fluids during labor. I'm sure on accident, but it was way too much. And I walked out of here looking like I had congestive heart failure. And then when the fluid shifted, it was a lot. It was a lot of fluid. So they will notice the symptoms to go with that in terms of having to go to the bathroom more often. And like I couldn't wear shoes for 2 weeks after I had my first baby. So these are like real things that affect them. And then it talks about symptoms on here. So watch for the symptoms of high blood pressure, which can be warning signs of things getting worse, like headaches, blurred vision, flashes of light, spots, easy bruising or bleeding, seizure, shortness of breath, chest pain, feeling unwell, nausea or vomiting, abdominal pain, especially in the upper abdomen. And so this sheet gives them a place where they can track their blood pressure and what medications they took. So that was a long presentation, but very important information. Please make sure that you come to us if you have any questions.